Hello, everyone. Since we're adding a little bit every week to the medications, and since every test is probably going to have something on it about medications, I thought I'd throw together just a quick overview of psychotropic medications. Tonight, I'm just going to cover anti-anxiety and antidepressant medications, since that's kind of what we're looking at in units 3 and 4. So how do psychotherapeutic medications work? Right? Remember, it's affecting the nervous system, primarily by altering chemicals. What are those chemical messengers? Neurotransmitters. These chemicals affect the brain, not necessarily the psychiatric diagnosis. So if you have major depressive disorder and I give you Zoloft, I'm not fixing the major depressive disorder. I am fixing your serotonin. This is why psychiatric illnesses are chronic lifelong illnesses, right? So we got adrenaline, that's that fight or flight. GABA, calming. Too little GABA, you have anxiety. Dopamine is pleasure. Dopamine is also seen in psychosis. Serotonin is mood. That's a lot of unit 4 when we talk about depression and mania, right? Those are kind of the important ones. Classes of medications: anti-anxiety, antidepressants, mood stabilizers, and antipsychotics. So I lied, we're going to go down through mood stabilizers tonight. Non-psychiatric medications are used in psychiatry. That's important, right? Antihistamine, hydroxyzine, Atarax, and Vistaril. Beta blockers, propranolol. Propranolol is a big one. We won't cover antipsychotics today. I'm going to put that in its own separate video for y'all once we get to it again. So anti-anxiety medications, what do we need to know? Right? Benzos are great. They were one of our first anxiety medications. We love them. They work for everyone because they're fast acting. If you have someone who comes in and they're having a panic attack, we give them a benzo because it's going to help the fastest, but it's going to wear off fast. Usually it's going to wear off in 4 to 6 hours. So they are going to need multiple doses throughout the day if someone has long-term chronic anxiety. So if we have someone generalized anxiety disorder, right, and they're anxious about everything, benzos would be the worst thing to give them because they're addicting. They're going to have to take more and more and more and more benzos, and as that tolerance builds up, it's never going to be enough. Withdrawal symptoms have stopped suddenly. It's a horrible withdrawal. I can get you off alcohol in 5 to 7 days, but it can take months to get someone appropriately off benzos. If you take too much, it causes respiratory depression. We want to give caution with the elderly, if anyone has COPD or sleep apnea. They also cause sleepiness. Buspirone and Lyrica we talked about in the very first lecture, that second week, unit 2. These are kind of normal medications, right? Buspirone, no sleepiness or muscle relaxation, but takes a few weeks to work. They're not addicting, but can cause headaches, dizziness, and nausea. It works well long term for anxiety, right? So if you have someone with generalized anxiety disorder, giving them buspirone would be an okay step. Lyrica is also used in seizure and neuropathic pain. So if someone has anxiety and pain, Lyrica is a good choice. There's less side effects, so there's more compliance. Honestly, your book and stuff talks about Lyrica. I've hardly ever seen Lyrica used, or at least not unless you have someone with neuropathic pain and anxiety, and then we give it because we can hit both at the same time, right? So those beta blockers, they are your LOL medications, right? Propranolol, atenolol, they're good for social phobias like agoraphobia, right? Anxiety causes palpitations, right? It causes headaches, muscle tension. So what do beta blockers do? They reduce the palpitations. They help with sweating. They help with tremors. They decrease blood pressure and heart rate. Nursing considerations, we want to monitor that patient's blood pressure. When you're anxious, you should be hypertensive. However, someone who's taking this regularly, or if we're going to give it long term and not PRN, we want to make sure the blood pressure is stabilized. When we get into antidepressives, SSRIs, they increase serotonin. In depression, you have low serotonin. SSRIs increase that serotonin. However, look at this list of uses, y'all. We use SSRIs in depression for individuals with OCD, PMDD, DD, right? We haven't talked about that quite yet. Premenstrual dysphoric disorder, bulimia, post-traumatic stress disorder, GAD, generalized anxiety disorder, and in social phobias, And honestly, we use them in more things. I just didn't list everything. They increase suicidality though. Big black box warning on SSRIs, especially in teenagers and adolescents. Why do they increase suicidality? Because they take 3 to 4 weeks, maybe 6 weeks to work for some people. When you have someone with major depressive disorder, they have such low anxiety that they might think they're better off dead, but they don't have enough energy to kill themselves. So as we slowly start to increase the serotonin, they see an increase in energy, and that increase in energy leads to suicidality. One of the things y'all have to watch are the names of these medications. That was a question that a lot of people missed on the first test, right? Citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline. See the patterns? These are your prams and your enes. More on SSRIs, patient teaching, side effects. Less than with other meds, right? Because of the low side effects, these are first line. Now, they still got side effects because let's face it, every psych med has side effects and every medication has side effects. But compared to, our benzos and compared to mood stabilizers and compared to antipsychotics, they're not as bad. We're going to talk about serotonin syndrome on the next slide. Do not mix meds, right? We want to educate our patients about serotonin syndrome, which is too much serotonin, and tell them not to mix meds and to tell us what meds they're taking. And you can see some withdrawal with SSRIs, so we want to tell them not to stop their meds. So side effects. Pretty much every medication, y'all, is going to talk about anticholinergic side effects. Can't see, can't pee, can't spit, can't poop. Headaches, hypertension, dizziness, and nervousness are also common with SSRIs. The serotonin syndrome. We're going to talk about this. We haven't yet, but we're going to talk about it in Unit 4. Rare but life-threatening. Cause is excess serotonin. Right? So when someone's depressed, major depressive disorder, serotonin is low. We give them an SSRI and it starts to raise it. But what happens when we raise it too high? You get serotonin syndrome. I always learned it as CAN. Cognitive, autonomic, and neuromuscular. CAN. So cognitive, right? Brain changes, agitation, confusion, hallucinations. Autonomic, right? Tachycardia. How are we affecting, your blood pressure, the fever, sweating? Neuromuscular. Hyperreflexia and clonus are kind of some of the big ones. If you see someone with hyperreflexes and they're on an antidepressant, we'd want to be concerned, but it can lead to loss of coordination and seizures. Now, this is a patient who they're depressed and they go to see a doctor and the doctor gives them an antidepressant, and then they go see a different doctor and that doctor gives them an antidepressant, but they don't tell the second doctor that they're on the antidepressant because 2 antidepressants are better than 1. It happens. Now, sometimes what you see is some medications increase serotonin that aren't SSRIs. One situation I had with a patient once where this came about, he was on tramadol. He had major depressive disorder. He cut his wrist so bad that he needed a whole bunch of sutures. He was in a lot of pain from having to have surgery. He actually had to get a tendon reattached. And we had him on an SSRI. Tramadol also increases serotonin. So we need to kind of be just generally familiar with serotonin syndrome. NRIs, serotonin norepinephrine reuptake inhibitors, these increase serotonin and norepinephrine. They're going to have more side effects than SSRIs because of the norepinephrine. We're going to get the serotonin side effects and we're going to get the norepinephrine side effects. Depression, generalized anxiety disorder, these are sometimes used in neuropathic pain and fibromyalgia, especially like Cymbalta. It increases suicidality. Why? Because it takes time to work, just like SSRIs. Desvenlafaxine, right? These are your enes and your prans. So when we go back, right, these are prams and enes. And these are enes and pran with an N. So similar names in your SSRIs and SNRIs. Just know, antidepressant, right, y'all? Enes and pran and prams, antidepressants. Right, cyclic antidepressants. aren't used quite often. Why? Because they're lethal in overdose. You want to give your patients just a few doses, right? It affects serotonin, it affects norepinephrine, it affects histamine, and it affects acetylcholine. So you have a lot more side effects. Anticholinergic side effects are still there. But all of that thrown together in an overdose, it causes cardiac arrhythmias. These are used, right? I have seen plenty of patients on these, amitriptyline especially, and nortriptyline, because these also work with neuropathic pain. So you do see them sometimes. Just know, right? Just like SSRIs has that black box warning with suicidality, these kind of have the same issues, but you also have to be afraid of an overdose. MAOIs, right, y'all? Any question that has to do with food, we're going to assume, unless it's grapefruit, that the patient's on an MAOI. It inhibits monoamine oxidase. Lots more side effects. Big nursing consideration is a hypertensive crisis with tyramine. Tyramine is in tons of foods, so these patients need a very strict diet. Usually because of this, if we're talking antidepressants, this is the last resort because of this, right? Think about your charcuterie platter, right? Out on your date night, significant other, got wine, beer, cheese, can't have it. Chocolate, can't have it. Preserved and pickled meats, fermented vegetables, yeast bread, soy sauce, fish sauce, and y'all, the list continues. Can't have pepperoni pizza, right? Salami, pepperoni, pickled meats, can't have it. I can't even say the names of some of these. Again, some of the ENS and IDS medications. Okay. New one for this week. Lithium. Uses bipolar disorder, right? Lithium is a salt. Your body excretes lithium at a faster level, right, through the kidneys because it is a salt. So we need to monitor their sodium intake, and we need to monitor their fluid and activity levels. Why? Because if you have a patient who, let's say they're really depressed and they start feeling better and they take up basketball one December, right, and they're playing basketball every day, and then all of a sudden it's June, July in Texas, it's 105 degrees outside, and they're playing basketball outside, and they've never played basketball outside, and they're sweating a lot and getting dehydrated, it can raise their lithium level. Lithium level is super narrow. It's a narrow therapeutic window, and toxicity is dangerous. So especially in the beginning, we need to monitor that level every month and then increased every 3 months. It can take up to 3 weeks to work. So we also need to watch anything that's going to cause dehydration. So vomiting, diarrhea, changes in sports, anything. When I was in the Army, we would not let a soldier be on lithium because of that dehydration, right? The different things we need to be concerned about to watch it. Lithium toxicity, y'all, I copied this straight from your book, right? Have to be familiar with, is this causing lithium toxicity? Normal is going to be 0.6 to 1.2. Toxic starts about 1.5, right? So mild toxicity, that's 1.2 to 1.5 range. Apathy, sluggishness, drowsiness, lethargy, right? They can't concentrate, tiny tremors and twitches. However, when you get to like a medium, ataxia, tinnitus, blurred vision, nausea, vomiting, diarrhea, slurred speech, right? Twitching is getting worse, right? So that's 1.5 to 2.5 is when you're going to see that ataxia, the tinnitus, the blurred vision, nausea, vomiting, diarrhea. If the level goes above 2.5, nystagmus, that's that weird eye movements, right? When you follow the doctor's pen and they make the little cross in front of you and your pupils follow it, that's nystagmus. It's a twitching of the eyes, right? Twitching. Irregular muscle tremors. Twitches of maybe just one muscle group. Y'all, if you ever see hyperactive reflex tendons, hyperreflexia, medication, right? We're going to be concerned for medication overdose, medication level, because we see that with SSRIs too and serotonin syndrome. Changes in level of concentration, consciousness, level of consciousness, hallucinations, grand mal seizure, coma, and death. So we have to watch our lithium levels. Mood stabilizers, haven't talked too much about them yet. These are a lot of your seizure disorder and epilepsy meds, but they work with mood disorders. You see them sometimes in bipolar. We need lab draws to monitor levels, but they're not as concerning as lithium. So lithium, it's a super tiny, right? That 0.6 to 1.2 over 1.5 and above is considered toxic. So it's a tiny window. These have bigger windows. Side effects, the important one I've always known is Stevens-Johnson syndrome. I've seen this especially with oxcarbazepine, that Trileptal in kids, and it's a rash. And it looks like the skin is falling off and like the whole skin is just burning and it just covers the body of skin falling off. It can happen in other medications, but you see it a lot for some of these, right? And this is where genetics and culture and stuff sometimes comes into play because there's actually warnings for individuals of certain ethnicities that we don't give some of these medications because they have a higher risk of Stevens-Johnson syndrome. So you'll see these sometimes for mood disorders, especially if there's a history of epilepsy. If we can't keep them on the lithium, if we're concerned about their levels, this is when we'll go to this. Okay, keeping this short and sweet, I'm going to stop this now. When we get to antipsychotics, you get to see the rest of my lovely PowerPoint. But if y'all have questions about meds or anything, just reach out and let me know. We're going to keep seeing these over and over again all semester.